Okay, so as I said, welcome to National Thrombosis Week Conference. My name's Tiffany Richards. I'm the CEO of Thrombosis UK. I'd like to introduce your chair for this session, Professor Catherine Baggott, consultant haematologist at Glasgow Royal Infirmary and co-director of the West of Scotland Haemophilia Comprehensive Care Centre. Unfortunately for Thrombosis UK, she's also a member of our professional advisory committee. So, hello, Catherine.
Thanks very much, Tiffany. Well, welcome everybody to the last day of National Thrombosis Week. So this morning, our session is coming to you from Scotland. We've got speakers from all around Scotland, north, south, east and west. And the title of this session this morning is Tackling Venous Thrombosis, Identifying Areas for Change. And basically what we're trying to cover here is, can we or should we be doing anything differently in various aspects of our thrombosis prevention and management? So we've got a real eclectic range of talks this morning, anything from managing difficult antiphospholipid syndrome to considering whether we should be using anything other than anticoagulation to treat venous thrombosis. I want to say I'm incredibly grateful to the speakers that we've got this morning who've taken the time to put their talks together and to be with us this morning. So without further ado, I'd like to introduce our first speaker, Dr. Leah Haskins. Now, I've had the honour of working with her before in Glasgow, but she now is a specialty doctor in medical haematology, working in haemophilia and thrombosis in Edinburgh. And she's taken on a few roles, but one of them is supporting the Perioperative Anticoagulation Service. And she's going to be talking today about what insights she's gained from being involved in managing that Perioperative Anticoagulation Service. So thank you very much, Leah. Over to you.
Thanks very much, Professor Baggott. Let me just share my screen. So just checking that that's all okay, that you can see that fine. So thanks very much for the opportunity to speak here today, and thanks to Thrombosis UK. My name's Leah Haskins, and I work as a specialty doctor in the Royal Infirmary of Edinburgh. And today I thought it would be quite relevant to discuss and talk to you about insights that I've gained from our Perioperative Anticoagulation Service. I think this is an important topic. It's a really good way to kind of share experience. And also, I think that the concept of antithrombotic stewardship has become kind of more popular, more relevant recently. And this kind of falls under that umbrella. Let me just time this. So these are my disclosures. And I thought I'd start off with a lovely, beautiful picture of Edinburgh, in case any of you wanted to come and visit this lovely city. I get to have a look at this view every morning on my way to work, which is lovely. So what am I going to talk to you about today? So first of all, I'll go over a little bit about why there is a need for perioperative anticoagulation service and what does our specific service look like at the Royal Infirmary. I'll go over a few cases really just to demonstrate how the service is run and how we input into the management of these patients. And I'll go over what the future of our service looks like. So in terms of why the service is needed, there are ever-increasing numbers of patients on anticoagulation and antiplatelet agents. I've popped a couple of figures in here. And you can see, I think, one of the most striking figures I saw were some American figures where they've estimated that the global use of antithrombotic medicines is projected to double by 2050. And out of those antithrombotic agents, so by antithrombotic agents here, I'm meaning anticoagulants and antiplatelet agents, up to 20% of people on these agents will undergo an invasive procedure each year. So we are going to be seeing increasing numbers of these patients. And of course, with any person going for a procedure who's on an antithrombotic agent, there's a delicate balance between the risk of bleeding around the time of surgery, as well as the risk of having a recurrent thromboembolic event at the time of antithrombotic interruption. With an increasing age of the population and increasing numbers of comorbidities in the population, this also increases the complexity in decision making. And, there will naturally be variation in practice across different specialties and across different regions. And I guess the question is there one right answer here? And what evidence base do we have to manage these patients, particularly in this kind of more involving complexity? So there are a few trials that I'm going to just briefly touch on, just to say that there is some evidence to guide us in these decisions. So I just wanted to mention the PAUSE trial, which was published in 2019. This was a cohort study of 3,007 patients. And just to highlight, these were patients with atrial fibrillation, so not patients who'd had a VTE, and they were all on a DOAC. There was a perioperative strategy of DOAC interruption, which I'm sure we're all very familiar with from our day-to-day practice if we do practice in this area. So this is without heparin bridging or coagulation function testing. And just a brief overview of what that looks like. I'm sure we're all very, very familiar with this. And this showed that there were low rates of major bleeding and low rates of arterial thromboembolism using this management strategy. And there's also a PAUSE 2 trial coming with the pilot trial published last year, comparing this PAUSE protocol with the ASRA protocol. So ASRA is the American Society of Regional Anesthesia, and it differs slightly in timing of DOAC cessation, and also it recommends coagulation function testing in some cases. So these two protocols will be compared in high bleeding risk surgery and neuraxial procedures. So hopefully we'll get some results in the not too distant future. There was also the Periop 2 trial in 2021, which was a double-blinded placebo-controlled trial, which looked at the efficacy and safety of post-op bridging with dalteparin versus a placebo in patients who were having warfarin interrupted for procedures, and they were on warfarin for atrial fibrillation and for mechanical heart valves. And this showed no significant benefit from post-operative dalteparin bridging to prevent major thromboembolism. Interestingly, there were similar bleeding rates between both of the groups as well. However, the numbers of people with mechanical heart valves in this trial was relatively low, so recommendations regarding management of these patients weren't able to be made. There's also a number of different guidelines that we can follow when making these decisions. We've, of course, got the BSH guideline back from 2016, which is, now 10 years old. I find the ISTH communication from 2019 very useful in that it recommended standardized reporting of procedural and surgical bleeding risk, and also patient-specific thromboembolic risk, which I think is important if we are wanting to kind of standardize treatment. There's also the American College of Chest Physician guideline from 2022, which made recommendations for various different antithrombotic agents for different bleeding risk surgeries. This made 40 recommendations, and I'd just like to highlight that 38 of those recommendations are based on low or very low certainty of evidence. So essentially, I think this highlights that in these cases, there's not always a textbook answer. In the context of this level of uncertainty, are patients' preferences being heard in this decision making, and how are decisions around kind of antithrombotic therapy, around surgery, being communicated with the patient and with the clinical teams involved? And I think this is a really challenging area. Here, I've kind of touched on it briefly about antithrombotic stewardship. This has become a bit of a more popular term, I think, in recent years. The Anticoagulation Forum, which is an American group, had an antithrombotic stewardship summit last year, and they released a communication in which they highlighted that antithrombotic medications remain the leading cause of preventable medication-related harm across care settings. And I think that's a really, really significant statement. And in fact, they've called this a public health crisis. So I think they're using really strong language here. They highlighted these issues through the ADAPT study, which was essentially a survey that they sent to multiple different centers around North America. And they asked questions about a variety of different topics, including management of perioperative anticoagulation. And they highlighted the following challenges. They highlighted that there is unclear ownership across services. And also, there are reactive monitoring practices across this area. They said there was minimal distinction between elective and non-elective procedures, and also limited adherence tracking despite existing protocols. And they made a few recommendations, which I've listed here, but I'm not going to go over all of them just now, as I'll come back to this later on when talking about the future of the service. So going on to what our service looks like in NHS Lothian. So we are based at the Royal Infirmary in Edinburgh, and we cover advice for the whole of NHS Lothian. We provide clinical advice to surgical teams through either the local guideline for the kind of more straightforward patients, and also a dedicated email inbox in which surgical teams can ask for advice directly. Of course, referrals come through other avenues as well, such as written referrals and phone calls. So a lot of the time we're able to just simply provide advice or reassurance. And in some cases, we document individualized plans for more kind of complex or more high-risk patients. We also do provide clinical review of patients, and this is mostly patients who require low molecular weight heparin bridging around the time of surgery. So generally, this is patients who are on warfarin, and we have a dedicated clinic for this. And we're able to bring patients in at pretty short notice to be able to go over their plans and make sure these are communicated to patients appropriately. And this next point is something that's probably a little bit more in development in terms of follow-up and oversight of these patients, which I think is particularly relevant in these patients who we're seeing in clinic and advising on low molecular weight heparin bridging. There are lots of, instructions that patients need to follow. There are lots of appointments that need to be made. And I think our service definitely has a role in bringing all that together and making sure that plans are being followed and have been communicated appropriately to the teams involved and also to the patient. So we have a multidisciplinary team, which includes our thrombosis specialist nurse, who has been a really, really valuable addition to our team. She's been with us for the last year, and I think this is a role that is still very much in development. We also have a pharmacist who has recently just had a baby and is on maternity leave, but we have also had some additions to the pharmacy team as well. And we have our team of doctors. So we have 3 consultant hematologists who work in Edinburgh in the Royal Infirmary, and myself, as well as an associate specialist doctor. So we're all part of the kind of permanent medical team. And we essentially communicate a lot with the preoperative assessment team. So generally, this will be kind of pre-op nurses and anaesthetists, as well as surgeons, and we draw advice from the cardiology and stroke teams as well, depending on what antithrombotic agents patients are on and kind of what indications they're on the agents for. And of course, communication with patients is also key. So how does our service support safe decision-making for these patients? So I think a really important role as hematologists here is clarifying risk. So patients who are on anticoagulation for VTE, can this safely be stopped? Are they high, moderate, or low risk for recurrence? And how are we managing these patients. And, generally, I would say most patients you can kind of follow a straightforward protocol, but there will be patients where it's not quite so easy to clarify that risk. I think there's definitely a role for shared ownership here, and I think shared ownership definitely increases confidence in decision making for the whole team involved, so all the different specialties, including the patient. I think having a service does also kind of increase consistency across specialties and sites, and the hope would be that this would improve patient outcomes. So just a few cases here that I'll go through quite quickly. This is just an example of an email that comes through to our dedicated inbox. So a 66-year-old man going for a knee replacement has a history of recurrent query unprovoked DVT a few years back, currently on long-term apixaban, further symptoms this year, maybe had an acute clot, maybe didn't, what is the risk of VTE here? And he's going for a knee replacement, which does have a high risk of post-operative DVT. So essentially, I had to just start kind of unpicking this, going through the patient's clinical record, figuring out, has this been an unprovoked DVT? Has this been provoked? Have they actually had a recurrent DVT? And if they had, did they have a recurrent DVT while taking prophylaxis? Because this really changes him from kind of more moderate risk to high risk and would alter our management here. And of course, these things do matter. So going through the history, in fact, this patient had a provoked DVT in 2020. He was treated for a recurrence of this the following year, having been off anticoagulation at the time, but it was the symptoms were in the same leg, and they had been quite persistent throughout. So was this in fact post-thrombotic syndrome rather than an acute clot? The patient then had pain and swelling in that same leg 7 months preoperatively. So this occurred while on anticoagulation. Clinically, this was probably a Baker cyst. They had a Doppler scan. There was evidence of clot there. Was this acute? Was this chronic? I think this is quite a familiar scenario to a lot of us. So ultimately, we advised the team to follow standard protocol preoperatively for apixaban interruption. And then we discussed whether there was a role to increase apixaban dose from the prophylactic 2.5 milligram BD dose to the 5 milligram BD dose from about 2 weeks to 3 months post-op, in that kind of post-op period where there would be an increased risk of VTE following his surgery. So I think there might be a discussion as to whether there's evidence base for this recommendation and whether this is, whether this is appropriate management, but that is what we recommended. Next case, got this email through, and another one to unpick a little bit. So please, could we have some advice for this complex patient going for a knee replacement? She has a high BMI, had a prior unprovoked pulmonary embolism for which she takes clopidogrel. We're planning to use mechanical measures and 6 weeks of low molecular weight heparin. So a little bit to unpick here. What is the risk here? They've had a VTE. Clopidogrel, I don't think, is a well-known and a preventative agent for prevention of recurrent VTE. Is there something else going on here? So looking back at this patient's history, yes, they had an unprovoked PE in the past, which was treated for 6 months with anticoagulation. They had then had a TIA for which they were taking clopidogrel. So some VTE risk factors here, as well as arterial risk factors. So the discussion around management of surgery here was regarding post-operative low molecular weight heparin, which, given her risk factors, high BMI, total knee replacement, history of VTE, we would definitely recommend a 6 weeks of post-operative prophylaxis. Then the discussion had to be made as to whether clopidogrel should continue while on low molecular weight heparin. This patient has a history of a TIA, and that's a discussion that had to be had with the surgeon and the patient. So I think the important thing here to highlight is that when patients come in for preoperative assessment, it can potentially highlight unknowns in their past, and these it prompts medication reviews. And I think it highlighted the importance of patient education here, because it wasn't quite clear to the patient, I think, and the pre-op assessment team why they were on clopidogrel. And finally, just maybe a little bit more of a kind of standard question that comes through to us as hematologists. A 70-year-old female going for a lobectomy for a new diagnosis of lung cancer, essentially needing surgery as soon as possible. They had the finding of a pulmonary embolism on their diagnosis CT, which anticoagulation was started for 2 weeks ago. They'd been started on apixaban. So I think the role of the hematologists here was essentially risk stratification and mitigation in this kind of high risk scenario. So recent VTE, only 2 weeks ago, and having to go for urgent surgery. So no real option to delay surgery. So the question here is, is there a role for an IVC filter? And the decision was made not to go for an IVC filter after doing Doppler scans of both of this patient's legs to exclude like a peripheral DVT. And also, is there a role for preoperative low molecular weight heparin bridging here in someone who is on apixaban, but in a very high risk scenario? So we saw this patient in the bridging clinic and discussed the plan with them, which included withholding apixaban for 48 hours prior to surgery and giving low molecular weight heparin in that the 2 days prior to surgery to bridge them. And I think the importance here was of clear documentation and clear communication with the different specialties and with the patient. So looking to the future for our service and perioperative anticoagulation services in general, we know that there will be increasing numbers of patients going forward. And I think what's a really important question is, in a healthcare setting that is under pressure and is resource poor, what is the role of hematology, anesthetics, and surgical teams in antithrombotic stewardship going forward? How are we going to reduce these adverse events? And I think there will hopefully be an ever-expanding evidence base and certainly expanding experience. So how can our service be improved? So I'd just like you to bring you back to those points earlier from that survey that was done in America. And I'm not going to go through all these points, but just to highlight the first point, which says define and standardize ownership of peri-procedural anticoagulation plans. And also the third point, improve structured data capture and routine reporting. So how can our service be improved? Well, I think this is definitely going to take a multidisciplinary approach. So, who takes ownership of these decisions? I think ongoing audit of current practice is really, really important. So, we have guidelines. Are the guidelines being followed? Are we capturing adverse events? Are we learning from adverse events? I think we will definitely be changing practice over time as new evidence emerges. And what I think is really, really important for our service going forward will be increased specialist nurse and pharmacy input. And I think this is particularly important in the kind of patient-facing side of our service. I think we also need to highlight the pressures on all of us and, the importance of allocating specific sessional time for management of these cases. And, probably most importantly, improving inclusion of patient choice and perspective in decision making. And I think, when there's a lot of uncertainty in evidence and a lot of kind of management of risk rather than having a definite right or wrong answer, patient choice is really key in making those decisions. Um, Thanks very much for listening. I'd just like to acknowledge Dr. Julia Anderson, our consultant hematologist, and Hazel Forrester, our thrombosis specialist nurse, for helping me create this talk. And if you have any questions, please let us know.
Thank you so much, Leah, for a really comprehensive talk. And I've got quite a few questions for you. So we've got a few minutes for questions. And let me just see that I'm just a couple more came in. Right. So going right to the start. So you mentioned the Periop 2 study. And I think you sort of alluded to this, but maybe you can just clarify. I think not. The question is, were all of those patients on valves? Did they all have valves? And I think not. How many?
No,
There were 1,400 patients. Do you know how many people had valves?
it was 20% of those.
Okay. So
Yeah.
so the anonymous attendee, you asked that question. The answer is 20% of the 1,400 had valves. So thanks for that. Then when you gave the second patient example, the knee replacement, the high BMI on clopidogrel, another attendee is asking, could we consider a DOAC post-op for that patient? What's your thoughts on that?
Well, I mean, I think we know, I mean, we know DOACs are licensed for post-operative thromboprophylaxis in this orthopedic surgery. So absolutely, I think that could be considered. I think it does kind of depend on the local protocols. I think there will be regions where DOACs are used as standard, I think. But our orthopedic team, I think, still uses low molecular heparin for post-op prophylaxis.
Yeah, it's similar here in Glasgow, and I think there's still a concern, isn't there, about bleeding post-operatively amongst our orthopedic colleagues. Then questions coming from Sue Bacon. Hi, Sue. So you talked about, I think this was the cancer patient who you'd mentioned you gave a couple of doses of low molecular heparin prior to the surgery. So Sue's asking, what dose of low molecular heparin did you use? I think you said you gave for 2 days, and she was wondering, did you give full dose on one day and then prophylactic, I presume, the day pre-op? What did you do?
Yeah, that's exactly it. So full dose on day -2 and then prophylactic on day -1.
Okay. And I would have asked a similar question to Sue here. We'd already discussed that there's no need to bridge with the DOACs. So why did you use low molecular heparin here? Apologies to be challenging.
Well, so it's really interesting because I have insight into different practices across different regions. And I think, in these high risk patients, it's really difficult because I don't think we have robust evidence, for particularly, when you're talking about just within that kind of first 28 days of a clot. And I think this patient was felt to be sufficiently high risk that we weren't comfortable with just having that kind of those 2 days off the DOAC without cover.
Yeah, and I think this is the thing with the lack of evidence, isn't there? We do have the really nice study looking at AF patients and being able to stop DOACs 48 or depending on renal function before, but not addressing high risk VT. Hence, more evidence is required. I've got more questions coming in now, but I will have to stop relatively soon. Let me just see if I can just tackle slightly different questions. Just bear with me 2 ticks. I suppose an interesting question. Is there a difference in bleeding risk between direct oral anticoagulants and low molecular heparin? Because obviously our orthopedic colleagues feel there is. What's your thoughts on that?
Oh, I'm not sure is the honest is the honest answer. I think I think the bleeding risk profile with DOACs is reassuringly quite low, I think. And I'm not sure kind of head to head. I might have to ask your opinion on that, Professor Baggett.
That's okay. I mean, I think my thought here would be, because there aren't head-to-head trials, but I think that my concern would be is that a DOAC has a longer half-life than low-molecular weight heparin.
Yeah.
So if you run into bleeding problems, it's going to be out of your system later, and that's very much why in the post-operative period, if you think you've got someone with a high bleeding risk, we would say we'll stick with prophylactic dose low-molecular heparin for the first 1, 2, even 3 days before you introduce a DOAC that's going to be around a lot longer, because the half-life of heparin is 6 hours and the half-life of a DOAC is on the whole about 12. So we'll have to stop there. Leah, thank you so much for a really comprehensive talk. And there's a lot of questions there, and we will see if we can answer them as we carry on through the morning. Right, so Leah, thank you so much. I'm very grateful now to introduce Dr. Peter Douglas as the next speaker. Peter is not a haematologist. He's an interventional radiologist and has a special interest in angiography and venography. And he's really got a specialist interest in using procedures in the treatment of venous thrombosis. And so he's going to talk today and really challenge us and talk about more than medicines, imaging and intervention in venous thrombosis. So over to you, Peter. Thank you so much.
Hello, good morning, everyone. Thank you for having me. First thing I should really say is that although I have an interest in this, I am certainly not a highly experienced or high volume user for any of these things. That has its pros and its cons. Obviously, the downside is that I cannot speak to the dozens and dozens of different scenarios that I've encountered when I've done this. I think the potential advantage of that is that it's maybe let me look at some of the evidence with a relatively unbiased set of eyes to try and tease out what we can and cannot say a bit more definitively in this. So I'm based at the Queen Elizabeth University Hospital in Glasgow. We work with a brilliant team, but we are not currently doing very many, if any, interventions for acute venous thrombosis. But I believe that there is a role for that and that we should be. So what we're going to cover today, I'm going to briefly talk about why should we talk about doing this, what actually are these interventions, does it work, and is there any evidence for this? And hopefully, if I've convinced you that there is some role for this, what next, and how do we incorporate this into our pathways? So apologies for this image relatively early in the morning. This is obviously a fairly severe case of a post-thrombotic syndrome with some features of ulceration on the medial side there. But PTS is the main reason of why we really care about DVT, along with the risk of pulmonary embolism. It can be a very debilitating condition. It's almost always lifelong, and these things tend not to improve significantly with time. There is some fairly good evidence out there to suggest that when severe, that these patients are really miserable. It really affects their quality of life. They don't like wearing their compression garments because they're uncomfortable, and often that's the only treatment that we can really offer. Venous ulceration is a waxing and waning thing, and even with one ulcer heals up, it can come back months or years later. And this affects society and our health and the NHS. These patients come back. Every appointment costs money. Some patients will be unable to work. It'll affect their lives and their families, and overall their quality of life it can be really quite heavily affected. You can treat these patients chronically. Just a very quick aside here. These chronic patients who do have long-term venous occlusions, with the right patient selection, they do sometimes have some treatment options. This is a single transverse slice from a non-contrast MR venogram, and you can see on the right side normal iliac artery and vein, and on the left side a normal iliac artery and completely absent left iliac venous system. This was a man in his 40s with fairly disabling post-thrombotic syndrome. He was unable to play with his young daughter. She kept asking him to take him out on our bike, and he just had to say, "I'm sorry, I can't. My leg is too sore." We managed to recanalize his occluded segment, stent it open with the right anticoagulation follow-up. He is now over 12 months post-intervention, and his symptoms have improved to the extent where it's no longer life-limiting. He can do whatever he wants, and it's hugely improved the quality of his life with his family. So what are our invasive treatment options for more acute DVT? So you can divide these into catheter-directed thrombolysis, where we're administering essentially alteplase into the thrombus, and this can be lysis alone, what we traditionally have given, or these days there's also the option of an ultrasound-accelerated lysis. I'll speak about some more of these in a minute, or thrombectomy strategies. And depending on the device and the manufacturer, these can be divided either into suction devices, a rheolytic device, which breaks down the clot and red cells using a high pressure spray. Surgical thrombectomy is still an option, although I think the vast majority of vascular surgeons find the results very unsatisfactory. And then there are some device-specific mechanisms there. So here are some of the options that we have. So this is a Cragg-McNamara catheter. This is a pretty old technology in IR. It is a plastic tube with multiple side holes. We would infuse alteplase in this over hours or over 24 hours. You can choose the length of the catheter depending on the segment you want to treat to deliver the alteplase directly into the clot rather than giving it systemically to try and achieve higher concentrations into the thrombus itself and low concentration systemically to minimize bleeding risk. A company have developed an ECOS catheter, what they call the ECOS catheter, to try and take this a step further. This has small ultrasound generating probes placed inside the same type of lysis catheter. So we also infuse lysis in the same way, but this high frequency ultrasound agitates the clot, and they have some laboratory data to show how it pushes the thrombolytic further into the clot to achieve a faster clot breakdown. The idea is to achieve, first of all, greater luminal gain, but also they've done some dose-finding studies in pulmonary embolism to show that you can have this equivalent clinical result with a much lower dose of thrombolytic, and therefore, hopefully, to correspond to lower clinical bleeding risk. There are also these non-lytic strategies. So this is the Indigo system from a company called Penumbra. And this is effectively a very specially engineered tube that you can navigate through the venous or arterial system, poke it towards some thrombus and suck it out. There's a collection bucket here where you can see how much thrombus and, importantly, how much fresh blood you may be aspirating, and that can limit the intervention there as how much non-thrombotic blood you're aspirating from the patient. This is a schematic of the angiojet device. This is the rheolytic mechanism that I mentioned. This device does not actually use suction, so it isn't always classified as a thrombectomy device. What it does is use a very high pressure but very small jet of saline. Effectively, it forms a pressure washer inside the vessel that indirectly causes a low pressure area at the catheter head where there is a channel there. So thrombus and fragments do break down and move through the catheter into a collection bag externally, but don't create a mechanical suction on it. There are some cautions with using this device. As the high pressure spray breaks up the clot, it can also break up the red cells and other cellular fragments inside. One of the components of that is adenosine, and if that flushes out into the systemic circulation, there have been multiple cases of profound bradycardia that can be caused there, so it does need use with caution for sure. This is the clot retriever device from a company called Inari, and this works just like a fishing trawler net. There is this stiffer coring element towards the base that is dragged through the veins to capture the clot and deposit it into the collection bag, and you can see how that it doesn't come out circumferentially. It comes out from directionally from one side of the catheter, so that you can do this kind of moving around the clock face to try and clear the vein the whole circumference. So that's what we can do. Let's try and talk a wee bit about patient selection and who we might do this, who might perform some of these conditions in. So first of all, DVT is not one condition. I think it's probably three. Infrapopliteal, femoropopliteal, and ilofemoral DVT often have slightly separate clinical presentations, and they certainly have different rates of post-thrombotic syndrome associated with them. Infrapopliteal DVT can be subclinical or with fairly mild clinical symptoms. Therefore, it's very difficult to know the post-thrombotic syndrome rate because we don't know how many cases are necessarily out there. Femoropopliteal DVT, everyone's very familiar with thankfully a relatively low PTS rate in the region of 20 to 30%. However, iliofemoral DVT, I think these patients tend to present with more significant symptoms as the thrombus propagates higher up and covers more of the collateral pathways for venous drainage. It leaves the lower limb with fewer options to decompress, therefore swelling and pain can tend to be worse, and they have much higher rates of PTS. I think a relatively accepted standard is in the region of 50%, and some papers will quote up to 80%. I looked up my local practice to try and see how we treat these different forms of DVT in different ways, to look for the flow chart of femoropopliteal DVT versus iliofemoral DVT, and it wasn't there. It was somewhat absent. Apologies for that. There is lots of information on our adult therapeutics handbook about how we risk stratify patients with symptoms of concerning for DVT, how we treat while waiting for the ultrasound. If the ultrasound comes back as positive, what we should do for the anticoagulation, and how we should follow them up and the duration of anticoagulation. There's also lots of great evidence, great information on there about thrombophlebitis, and depending on its length and proximity to the saphenofemoral junction, etc., advice for pregnant patients and intravenous drug users. Lots of that, but we don't have anything to differentiate thrombosis below the inguinal ligament compared to above the inguinal ligament. So, how do I think that we should treat DVT? Well, from an interventional or procedural point of view, there's a couple of principles of treatment that you need to be aware of. The flow dynamics is one of them. So the inflow, the target lesion, and the outflow. And regardless of what body area we're treating, arteries, veins, etc., if it's flowing blood, we need to consider these parameters. The other main one is the age of the clot. I'm going to talk about this first. So, of course, when clot forms, fresh clot is a very fibrin-rich matrix that catches aggregated activated platelets and red cells, etc. And over time, this matrix matures and starts to change its makeup. So that by day 7, it's got approximately 20% of collagen inside it, and that by day 21, it can be up to 80% collagen or thereabouts. We have loads of experience from the arterial system. If patients present with acute ischemic limb, that in the early stage, it responds well to surgical thrombectomy of getting that out. But as the clot ages 2-3 weeks down the line, it feels different. It looks different to the surgeons when they get it out. It becomes more adherent to the wall and it's harder to treat. I think this is one major reason for our non-responders to anticoagulation. Although patients may have symptoms that are 24 or 48 hours long by the time they present, the clot may have been much longer before it increased to a certain size where it triggered symptoms. Anticoagulants and thrombolytics do nothing for collagen. And even if the clot's only been there for 7 days, if it's about 20% collagen, then 1/5 of the clot isn't going to be disrupted. And I think this is why some of our patients develop PTS despite excellent treatment. So principles of treatment in terms of flow dynamics, inflow, target lesion, and outflow. So if we're going to clear thrombus from our veins in the lower limb and the pelvis, we need to have good flow through the deep veins below the knee, which we don't really do a lot to look at or image. It's difficult to image. They're very small structures, and we don't have a very good way of differentiating between these, but I will talk about that a bit more in a minute. But in terms of the outflow, the classic thing we're talking about is May-Turner. So you're all familiar with the idea of the left common iliac vein being compressed as it passes underneath the right common iliac artery in a classic pinch point. Higher rates of left-sided DVT, certainly left-sided iliofemoral DVT, and where this happens, the appropriate treatment is often a venous stent to open up this narrowing and prevent recurrent thrombosis. Here are a couple of cases to highlight these flow dynamic principles. Special thanks to Dr. O'Hare from NHS Lothian for this. This is a woman in her early 40s. She was a factor V Leiden homozygote. She had recurrent DVT on anticoagulation, for which she had previously had an IVC filter inserted. She was being anticoagulated long-term with low molecular weight heparin, and she had a new left-sided iliofemoral DVT despite that. Here is a coronal reformat of her CT venogram, and hopefully you will believe me that it shows expanded low density vein, absent of contrast, all the way up to the level of a May-Turner lesion here, just at the caval confluence. So after a couple of days of anticoagulation, my colleagues in Edinburgh decided to treat this, and initially they used catheter-directed lysis. This was infused overnight and brought back the next day for a lysis check in interventional radiology, and you can see that they have had fantastic response to lysis. The femoral, so the iliac segment of the vein is completely patent, but what you may or may not immediately appreciate is that this is a strikingly abnormal venogram. The contrast is being ejected here from the top of the common iliac vein, and rather than flowing away up the IVC, it runs downwards, down through the pelvis towards the femoral head, and then fills all these venous collaterals. All right, and hopefully you'll notice at the top of the screen, there's a very abrupt cutoff of this vein here, and this is her May-Turner lesion, where the artery is compressing the vein, and there's just no flow through of blood in contrast through this. So within 48 hours, this had completely rethrombosed, despite all the good work that she'd had done before. She was taken back procedurally, and they used the one of the suction devices, the Indigo device I mentioned earlier, to suck out all the thrombus. And then she was treated with a venous stent to treat her May-Turner lesion. She has been free from DVT for, I think, 14 months now, with appropriate anticoagulation there. And you see the difference between the static column of contrast on the left of the screen and then the immediate flow through to the IVC and through her IVC filter on screen right through the stent. It's also worth noting that some of these images have been manipulated to flip them left to right, because some of these procedures were performed with the patient lying on her back, and some of them were performed with her lying prone flat on her front, so that we could access the popliteal vein. Something to bear in mind for our patient body habitus when we're selecting patients for intervention here. This is another man in his 40s. He presented with right-sided iliofemoral DVT. CT venogram here shows an expanded common femoral vein here full of clot, and the coronal reformat, you can see it extends above the inguinal ligament into his external iliac vein all the way through his femoral popliteal segment. This was my case here in Glasgow. I elected to use the Inari clot retriever system here with this trawler net approach, and this is what it looks like as it gets dragged through the veins. And this is the material that I got out. So quite a lot of thrombus from his iliac and femoral popliteal segment. And these are the pictures of the flow through the vein at the end. So you saw in the CT how it was completely full of clot and how all of this has been removed now. And because this was the first case of this that I had done, I wanted to follow up this man closely. So I brought him back for an MR venogram at around 6 to 8 weeks. And he had some foci of thrombus in his right femoral popliteal vein despite that. Although most of the clot was cleared, he still had a few things there. And this is predominantly, I think, because of poor patient selection on my part. The main factor in this gentleman was the precipitating event in him was that he had foot surgery about 2 to 3 weeks before and had minor wound infection. So his clot had started in the deep veins of his foot and ascended through his popliteal vein, through his deep veins of his calf, then through the popliteal vein and upwards. He had very little inflow. I actually had to put a needle into his posterior tibial vein at his ankle and lace his popliteal vein with thrombolytic and agitate it and balloon it and suck out as much clot as I could before I could actually get my main thrombectomy device in. So I think I didn't know enough about patient selection in this case, and I chose someone who maybe should have had anticoagulation in the first instance. Worth pointing out that this MRV shows a significant anatomical variant of an axiofemoral trunk. That is, that the popliteal vein continues directly up through the thigh in direct continuity with the profunda vein, and that his femoral vein is actually very attenuated. It's this deep vein that's doing the vast majority of the venous drainage of his leg. The important factor for that is that because it's so deep in the thigh, it's very difficult to see on ultrasound, unlike the femoral vein. So, do these sorts of interventions work? Well, the quality of evidence isn't great. The ATTRACT trial was supposed to be somewhat definitive in this regard, and once it was published, it was criticized very heavily. So it had real problems with recruitment, and it included many patients with femoral popliteal DVT, almost 44%. Given that its major outcomes it was looking for was features of post-thrombotic syndrome, and we know that the rates of PTS in this group are relatively low, this significantly diluted the effect. Also, it was a very non-standardized intervention arm. Some patients were treated with lysis alone. Some of them were treated with lysis with a form of aspiration thrombectomy. And there were extremely variable rates of stenting of an underlying May-Turner lesion between the different centers involved. So very far from ideal. The CAVA trial was another similar trial. It was ultrasound accelerated lysis using urokinase, not alteplase. There was no thrombectomy performed, and it was exclusively in acute patients with who had symptoms for 14 days or less. Again, they struggled for recruitment. This was done in the Netherlands across, I think, 15 centers. It took 7 years to recruit 184 patients, so relatively small numbers per center per month. The procedures that they received were also relatively heterogeneous in terms of adjunctive balloon venoplasty and whether or not they got stenting of an underlying stenotic lesion or not. And again, neither of these trials showed a significant effect from intervention. More recently, a real-world registry has been published. Again, this is an industry-sponsored trial by the company Inari, who make the ClotTriever device, the trawling device I showed you. This was 500 patients who've been treated with mechanical thrombectomy. They were all iliofemoral DVT, no femoral popliteal. It was very safe, very few device-related significant adverse events. Over 99% was a single session, which is important for us as interventional radiologists. When we give lysis, we know we're bringing patients back the next day to assess the result of that. So in terms of workflow, it's more complex, whereas a single session procedure is very attractive to us. Very little blood loss compared to some of the suction ones. And they actually sent all of the material from this. I think the vast majority of this was sent for histology, and there was no valve damage. They didn't rip out any valve or endothelium or anything else related to that. They also asked the operators to describe the material that they got out, and I think this is really interesting, and it goes back to the point I was saying about the age of the clot. A third of the time it was clearly acute, soft, fresh thrombus. A third of the time, roughly, it was subacute, but a third of the time it appeared very chronic, very pale, white, fibrous, and firm to the feeling. And again, these were all patients who had symptoms for 2 weeks or less, and despite that, a third of the patients had very chronic looking thrombus. The thrombus is older than the symptoms suggest. there has been some follow-up to this. There's a subgroup of 285 patients who were followed up for 2 years, and they measured their Villalta scores at baseline and then across 2 years of follow-up. And you can see how they went from a very high percentage of moderate to severe scores for Villalta to about 6.5% between moderate to severe. And of course, compared to our published headline rate of about 50% for iliofemoral DVT, I think this is quite attractive in terms of a potential treatment option. Professor Stephen Black at St. Thomas's in London led a research group that did an economic analysis on the CLOUT registry. They performed matching of the patients from the anticoagulation arm of the ATTRACT and CAVA studies that I mentioned earlier on, followed them up in terms of the rates of PTS and the expected cost of that, and found that mechanical thrombectomy and early intervention was cost effective in terms of reducing costs to the health service overall. I think that this kind of pie chart, donut chart here at the bottom is really interesting, and that patients who had mild symptoms, of course, had relatively little benefit from that. Moderate severity obviously had some cost saving, but that there's a really significant cost saving to be made in patients who had more severe symptoms. Worth mentioning that this is a graphic adapted from the industry material, not from the original trial itself. That same company, Inari, are sponsoring the Defiance trial, which is a prospective RCT of thrombectomy versus anticoagulation alone. It's recruiting just now. Recruitment should finish later this year, and the results are expected in 2027. At present, I think the published RCTs are fairly poor, and I would put more weight on the real world data compared to a poor RCT. And although the criteria that NICE uses to select treatments does not really reflect this, the European guidelines do, and the 2025 European Society of Vascular Medicine guidelines for treatment of venous thromboembolism leave plenty of room for interventional treatments for selected patients with iliofemoral DVT. So timing of intervention, the timing of this clot, I think is also really important. Many patients with DVT will do very well with anticoagulation alone. Yeah. And all the trials so far have focused on the acute phase. So a lot of these patients who the trials are treating on may have responded fine to anticoagulation anyway, but you don't know whether or not they're going to respond until at least 2-3 weeks down the line. And at that point, most of the fibrin that your fibrinolytic is going to work on has been replaced with collagen. So pursuing a fibrinolytic strategy, I think, can only be used if you're going to treat patients acutely. However, then your number needed to treat is going to be quite high because many of your patients would have responded to conservative management only. So I think personally, maybe we should be using non-fibrinolytic strategies and selecting patients who are non-responders to anticoagulation to try and get the best bang from our buck and to push our number needed to treat for intervention up a wee bit. I thought this is a really nice paper. This was I think 387 patients from 8 different centers in Canada. They followed them up with Villalta scores after their DVTs. And they found that patients who had severe symptoms at 1 month continued to have severe symptoms for years. And that if you had mild symptoms or moderate symptoms early on, that you did not tend to progress to develop moderate or severe symptoms over time. So I think this is really helpful to say that the patients who fail to respond at, let's say, the 4-week mark are probably going to be the patients who will be coming back 2, 3, 4 years down the line with their severe PTS. So who do I think should get this intervention? Patients with iliofemoral DVT, with severe symptoms and lack of early resolution. So with that in mind, how can we incorporate this into our systems. So I think the ultrasound support for a positive DVT exam should say the thrombus extends above the inguinal ligament, if it does, that should prompt some form of severity assessment. Patients with a Villalta score above a certain level should be followed up around the 3 to 4 week mark. If they still have severe symptoms with lack of response to anticoagulation, this would prompt some sort of imaging to assess their burden. We want to see the inflow, the target lesion, and the outflow so that we can select the appropriate patients for intervention. So what would our flow chart look like? Something a little bit like this. So if clot is below the inguinal ligament, routine care, but if above the inguinal ligament, Villalta score. Mild or moderate, routine care, or if severe, we follow up. If they've improved, routine care. If persistently severe, then we go for, I would say, an MR venogram. If that shows their unsuitable intervention, routine care, bad luck. But if they have suitable inflow and outflow, they should be referred to interventional radiology and or vascular surgery, depending on your local setup, to consideration of thrombectomy and offering treatment. Now, just briefly, why have I said MRV? Here's the CTV I showed you earlier on, and with the eye of faith, if you squint a bit, hopefully you can all see the thrombus here on the left side. But here, certainly in Glasgow in the west of Scotland, we're very used to doing venography. We perform this routinely in our arterial patients. Lots of our arterial patients will have fem-pop disease that may need a bypass, and we can assess the great saphenous vein in excellent detail here to tell the surgeons whether it is or is not suitable to use as a bypass conduit. But the same exam also shows the deep veins extremely well. And this patient who presented with right leg claudication to the vascular clinic actually had right-sided femopopal DVT as their reason for leg claudication. So we have really good images. It can show you the deep veins further inside the thigh that the ultrasound may struggle to see, such as the profunda vein. Also, this is a contrast examination. So that requires a Venflon and the cost of giving contrast. However, we also have the option of using non-contrast techniques. So this, for example, is a non-contrast, really simple sequence. Every scanner in the country can do this. If they don't know how, I can tell them how. This very quickly shows the May-Turner lesion, the chronic thrombus in the external iliac vein. It helpfully shows that the femoral vein and the profunda vein are patent, and that patency is propagated through the femoral vein, and that my target lesion target for puncture in the popliteal vein is also patent. And because this doesn't require contrast or IV access, this could be done on, let's say, one of our outpatient scanners that runs on a Tuesday evening, for example. That hugely increases the ease with which that we could get these patients scanned and followed up, and I think smooth out a system. So, iliofemoral DVT, severe symptoms, are they not getting better? I think they need more than medicines. Thank you very much for having me.
Thank you so much, Peter. That was huge food for thought. Now you'll see that we're running a little bit behind schedule, but that doesn't matter too much. We've got 10 minutes at the end to catch up, so I'm not worried we're running over time. Interestingly, I think there are quite a lot of questions, but I think you managed to answer them, almost all of them, towards the end, because you've said who you thought we should be referring. The thing that's going through my head is, lack of resources to make sure that those patients are assessed, getting a Villalta score, being seen at 4 weeks. But I think you've answered a lot of the questions here. But one thing that has been answered, one question I think we should get answered now is, I'm probably going to say your name wrong, Dr. Horchy, Dr. Caroline Horchy. What if you've got someone who hasn't had all those lovely assessments done up to 4 weeks post-diagnosis, and there they are with their absolutely awful post-thrombotic syndrome? I suppose like the Kahn paper, those people who had severe PTS right at the beginning, 2-3 years down the line, they've still got very severe PTS. Can you do anything for them?
So this is, sorry, 2-3 years down the line?
Yes. Yeah.
Okay, so it depends on the specific burden of their disease. But yes, lots of centres in the UK are treating huge numbers of patients with chronic venous stenosis and occlusions. We have started treating them here in the west of Scotland over the last couple of years. The key is in the chronic patients. Obviously, the age isn't important; they're all old. But those principles of inflow, the target lesion, and the outflow that I said. So it does depend on the anatomy of what they have. Iliac segment is ripe for intervention. So your kind of classic patient with a May Turner, or maybe if they had pelvic surgery or some other reason and they have right-sided pelvic venous occlusion. Those are the segments that we can treat and often should be treating. But in order to keep that stent open, you need enough venous flow through it to prevent thrombosis from stasis of flow. So it's all about assessing the inflow in the femoral popliteal segment. Many patients will have disease involving the femoral vein, but if you have good flow through the profunda vein, then that can be enough to maintain a venous stent. So I would say yes, there definitely is potential to treat many of these patients, but not all of them, but many of these patients. And it can be a bit more tricky than doing the acute ones. I would say go and speak to your local vascular surgeons or interventional radiologists or whoever you have about saying these patients are miserable. How can you assess them to try and say if they could be a candidate for a venous stent? If there's no appetite locally, then many of these larger volume centres will receive referrals out with. And some of our very complex patients that I don't think I have enough experience to treat locally, they're being referred to we actually refer to London here, but there are centres elsewhere, Oxford, some people in Newcastle, etc. But ask around of where is most appropriate locally. I think these patients have been underserved. But yeah, it's all about the inflow. And because many of these chronic patients may not be able to be treated, and it's predominantly because of this inflow disease, either the profunda vein or the femoral vein, that means we can no longer treat the iliac bit. I think these are the ones that are the real driver of why we should be intervening in select cases in the acute or subacute phase, because once they become chronic, some of them are just no longer suitable. We've just missed the boat.
Right, thank you so much. We'll need to leave it there to be on with the next talk, but honestly, you've really given us loads of food for thought. Thank you so much for your time. Brilliant. Thank you. So without further ado, I'm going to move on to our next speaker, Dr. Paul Ames, who works in Dumfries, and he's our Southern Scotland representative. But in fact, Dr. Ames is originally trained in Italy and has been a consultant hematologist for over 20 years. And his particular interest is in antiphospholipid syndrome. Without further ado, his talk is now going to be on Plasmacell and B-cell depletion in antiphospholipid syndrome, a novel approach for different cases. Thank you very much, Paul.
Can you hear me?
We can.
Let me see if I can get the screen. I can share the screen. Can you see my screen?
We did briefly, and then it disappeared again.
Wait a minute. Can you see the screen?
We can see you now.
Oh, you can't see the screen.
I can't see the screen. It's all right. It's okay.
Now share the screen. Can you see it?
We can, yes. Thank you.
So I'm going to present you 5 cases that will variably be treated with different plasma cell depleting agents, which I've been involved directly or indirectly with 3 cases, and 2 were coming from the world literature. So the first case was a lady, a 57-year-old lady whom I met when I was down in London, who was diagnosed with primary antiphospholipid syndrome for 2 DVTs between 1996 and 2004. The second episode happened with a normal INR. When she came to England, the lady was from Argentina. At subtherapeutic INR, she developed some skin necrosis, probably because of imbalances with the natural anticoagulants. Then between January and February 2013, she's kept some skin papules that apparently were microthrombi at a therapeutic INR. In 2009, she was diagnosed with stage A BCLL that progressed to stage C 4 years later. And then as part of a trial in 2013, she underwent 6 courses of rituximab with bendamustine. And at the end of the treatment, this is the anticardiolipin titer in the box on the upper left that dropped down to about 40, then to 30, and then after in May 2015 it was still around between 20 and 30. The DRVT ratio dropped down to 2.2, then to 1.8 and stayed 1.8 until May 2015. That's the time I have in terms of follow-up from my colleagues down in London. The anti-beta 2 glycoprotein 1 dropped down as well with a slight increase at 35 in May 2015. This is an addition to the little slides that I had generated at the time, while the APT ratio continues to stay down. Interestingly, those skin microthrombi, she was continuing warfarin anyway, disappeared after the second bendamustine and never recurred during a time I was there, and I'm told until May 2015. But after May 2015, all the antiphospholipids, whether by immunoassay or clotting assay, slowly came back. This is another case I found in the literature for this presentation a couple of weeks ago. So it's the story of a 20-year-old female. At the time she was diagnosed with antiphospholipid syndrome, she developed a pulmonary embolism and she was also on HRT. She was started syndrome and hydroxychloroquine. 2 years later, she had a recurrent pulmonary embolism with an INR 2.8. Syndrome was stopped and started low molecular weight heparin plus aspirin. And after a month of that switch, she developed a recurrent idiopathic DVT. And then she was switched from low molecular weight heparin to intramuscular unfractionated heparin with marked extension of the pulmonary embolism 2 days later. She had 2 plasma exchanges followed by 4 doses of daratumumab, which is the anti-CD38 antibody, on days 0, 7, 4, and 21. There were improvements of the symptoms and signs of the DVT and the P from day +1, and she was discharged on therapeutic low molecular weight heparin. And 2 years later, she had a recurrent thromboembolism in the leg because she unintentionally stopped, or by mistake, stopped them or forgot. Didn't take low molecular heparin for 6 consecutive doses. So this is quite a complex graph, but just to say that at the top left here, this is when she got the plasmapheresis, and you can see that the actual DRVT in the anticardiolipin indicated in the continuous blue line, and the DRVT or the anti-beta 2 in the continuous brown line tended to decrease, and then they went up soon after plasmapheresis. So she received, with the 4 red arrows, the daratumumabs, and then all the antibodies reached a trough at day 108 post-treatment. That was probably 70 days later. And then they slowly came up. And interestingly, they also reported, which I added on this green curved line that you see here, they reported the D-dimer levels from the time that she presented pre-treatment with the plasmapheresis. The dimer went slowly down, bearing in mind at some point she was on low molecular weight heparin, and then when the antibody went up, the D-dimer went up, which is quite significant considering that when she went up around this area, she was switched back. She was on still continuing low molecular weight heparin. So there was a decrease in the antibody levels. This was a case that we treated here. She was a 46-year-old lady that was diagnosed with, she had ITP in her first pregnancy, during which she had an early miscarriage. She became pregnant again in October 2002. That was a term pregnancy, but she had thrombocytopenia throughout, and the platelet count out with pregnancy was just below 50. And at the time, she was anti-IgG IgM anticoagulation positive. She moved to Scotland in 2006, developed further features of thrombocytopenia, underwent a bone marrow that was compatible with ITP, and she was managed with steroids. A year later, she became pregnant for the third time. She had a cesarean section, and during the pregnancy, her platelet count reached a trough of 20 by 10 to the 9 per liter. At that time, she was lupus anticoagulant positive, both in APTT and the RVVT. I wasn't able to dissect whether that was positive within or without pregnancy, but it's been repeated. But she had negative anticoagulipins. Then in 2009, she developed some features that made her diagnosis of systemic lupus. She was photosensitive, had a positive ANA and double-stranded DNA. She was ROB60 positive. She had antiphospholipid expressed in the lupus anticoagulant. She was diet antiglobulin test positive, and she had ITP. She continued with the steroid that she was juggling before and started hydroxychloroquine. Then she developed an acute ITP in the subsequent months. She was given rituximab in a rheumatological dose of once a month up to December, with a short response to the platelets from 16 to 191, but that was short-lived. And she was juggling the steroids all along. Then, this is expressed in this figure here. Then at some point, where it says 50 in red on the right-hand side corner, she was started oil thrombopag. That wasn't successful much in bringing up the platelet count, and she was shifted to romiplostin. She started with 1 microgram per kilogram. That was built up to 125, and when the platelet count went up in red here to 123, it was a relatively rapid increase over a period of 2 weeks. She developed what appears to be an acute kidney injury with the eGFR that went down to 10. She had an Adams 13 measure that was 44. There was a blood film compatible with some fragments. And eventually she had a kidney biopsy showing microangiopathic picture. She received 1 dose of rituximab alongside the first dose of bortezomib in the myeloma dose, and little by little, the eGFR improved over the subsequent months and years. The platelet count went back up and never required any further support. The hemoglobin was low before treatment, went back into a normal range, and the RVVT just before treatment was 2.4, with the APTT being 1.922. The DRVT post-treatment went down to 122, but then after probably a bit more than a year, it went up to 1.9. So the additional findings was the kidney involved biopsy showing acute thrombotic microangiopathy. She had cardiac involved with an end stain with a troponin of 86. The echocardiogram demonstrated pericardial effusion with a grade 3 diastolic dysfunction with different motion defects of the left ventricle, and the CT scan also showed bilateral pleural effusions. So a final diagnosis was an almost catastrophic antiphospholipid syndrome, because you need 3 criteria, 3 different area of occlusions to define catastrophic. And this probably was induced by a rapid rise in platelet counts. Now, I just wanted to say here that remember that antiphospholipid syndrome platelets are hyperactivated. So if you go from 20 to 150, you got a sudden load of platelets that could do something into the arterial system. So be careful when you want to raise platelets in somebody with thrombocytopenia and antiphospholipid. This is another case I picked up from literature 2 weeks ago. This was a lady, a 50-year-old female, essentially with refractory ITP. She was diagnosed with lupus-related antiphospholipid age 42. They don't say what feature of antiphospholipid she had in the case report. She failed a number of agents for the ITP, cyclosporine, mycophenolate, have the same mechanism of action, by the way, intravenous immunoglobulins, and steroids. And she went on to get 2 doses of daratumumab, the anti-38, 2 weeks apart. Now, after 4 weeks, her platelet incremented from 21 to 107. And the disease activity for lupus went down from 18 to 6, and she not relapsed with the ITP at 1 year follow-up. Why did I bring it up? Because they show the RVVT here in the brown graph, where it was just above 2 in ratio, probably before the daratumumabs. It went down to 1.5 and kept so until the follow-up that was probably 40 weeks. And then this is the case we're dealing at the moment. He was a 50-year-old man who had 1 week of nausea, gastric abdominal pain, and temperature, presented to casualty with the same. Temperature was a bit higher, his blood pressure was low, 60/40 with a pulse of 111, CIP was 316, and a low EGFR. So they felt he had septic shock, and he was transferred to critical care. He had a number of viral and bacterial tests, including TB, that were negative. His plasma cortisol was at low end of normal. He had a low complement, a positive diet antiglobulin test with IgG and C3d. Hemoglobin was low with a slight increase of bilirubin at 25 millimoles per liter. Platelet count was low, and the CT scan, which you show the image here, showed bilateral adrenal hemorrhages. So, interestingly, in this column, you can see his baseline clotting assays. His prothrombin ratio was already 1.7. The APT ratio was 8. Never seen an APT ratio of 8. The DRVT screen was 5.35, confirmed 179 with more than 40% correction. Very high titer of anticardiolipin, significant titer of anti-B2 glycoprotein 1. He underwent 3 plasma exchanges, and after them, the PT ratio normalized. The APTT went down, as well as the DRVT screen. The anticardiolipin was removed. It was down to 237, and he was started on 90 milligrams of prednisolone because of the residual thrombocytopenia and hemolytic anemia that then slowly settled after the ensuing months. And he started rituximab and bortezomib only 3 weeks ago. We're hoping to get something done a bit earlier, but there was no space in the chemo clinic. But you can see that only after 2 months, the APT ratio went back up normal. The PT ratio is up to 1.2, and the DRVT went up to 5.8. The patient has the criteria for lupus indicated there. Sorry. So the issues with this patient is that we cannot use the INR to monitor warfarin, and we're resorting to have an in-house chromogenic factor 10 measurement. With such a high titer of antiphospholipids, I didn't want to wait to get a repeat titer. As I spoke to the people at University College, I presented the case at the European Forum in Lisbon at the beginning of March, and they all agreed not to wait a second test for antiphospholipids. That said, he's had it anyway post plasmapheresis and just before his treatment with the bortezomib and rituximab. He's been treated with low molecular heparin with anti-10A monitoring. And we hope that the plasma cell depletion reduces antiphospholipids to a medium lower level titers in order that it's not exposed to such a risk of recurrence. And let's start with an antioxidant, coenzyme Q10, 400 milligrams daily. Just to give you break down what I can do with 5 cases. So the longest period during which the antibody was low was bendamustine. Remember, it's an alkylating agent, so it wipes off your plasma cells. I thought a lady was treated for CLL. Bortezomib only gave a 20-week remission of the antibodies, and the 2 cases with daratumumab gave a longer sort of antibody remission. This is in keeping with some studies done in lupus, where they treated patients with bortezomib, and they realized that the plasma cells were repopulating the marrow probably after 15 weeks, and the antibody were coming back after 28 weeks. While with daratumumab, the depopulation happened a bit later because daratumumab acts also on plasmablasts and plasmablasts, and not only on plasma cells. So what's the rationale for plasma cell depletion? Just remember that in any immune response, you've got B cells stemming from the lymph nodes that become mount an IgM. They undergo an isotype switch, making IgG or IgAs or IgD. They become plasmablasts. They have a transient phase in the bloodstream, and then they seed in the niches, which are the bone marrow, spleen, and eventually the mucosal surface of all our body. And remember that beta-2 glycoprotein 1 is in its circular form, is a non-oxidated protein. When it becomes oxidized, it opens up, and you might see with the antibody response. Bear in mind that these people, if they are constantly exposed to an autoantigen, therefore they continuously having this process of B cells becoming plasma cells. So what causal treatment, and just putting this slide just as a thought, does the oxidation come first? So what allows the beta-2 glycoprotein 1 to open up to an open form and stimulate the antibody response, which then includes the plasmablast, the B cells becoming plasmablast and making anti-beta-2 glycoprotein 1s, or is the antibody coming first that binds to the beta-glucoprotein 1, that opens up, becomes oxidated, and you perpetuate the antibody response. So in my logic, but this has been demonstrated for hydroxychloroquine, the logic would give an antioxidant to keep the actual beta-glucoprotein 1 in a circular reduced form to minimize the constant exposure to the autoantigen, give a B-cell depletion to switch off the B cells becoming plasma cells, and carry on with plasma cell depletion in as much as you see the antibody level decreasing to a certain titer. In the last guy we are treating, we're going to measure his anticoagulopin after 4 doses of bortezomib and see what happens, and then continue eventually. He's been warned about the risk of infection. And I'll stop here, and I hope you enjoy your phospholipids, and thanks for listening to me.
Thank you, Paul. That was really, really interesting. There's a few questions that have come up, and I've also been thinking along similar lines. But the first I'm going to ask you is, someone has asked us, what made you think of antiphospholipid syndrome in patient 5?
Because what makes me think that
Yeah, what made you think that you were dealing with antiphospholipid syndrome?
The fact that he's got a high titer anticoagulopin and anti-beta 2, and the prolonged clotting, the prolonged lupus anticoagulants.
But what made you test for it, I suppose, in the first place? Maybe is what the
because when he had the clotting screen done in house, the PT was already prolonged. Was in our system was 2.4. And the APT was 2.7. Then we sent it up to you, and that's prompted the investigations.
Right. Okay.
We also, I thought at some point, he might have had the antiphospholimia syndrome, but then I wasn't prompt enough to request a specific test. But then it's also panned out as being an antiphospholipid syndrome. He didn't bleed. Well, he had the infarction in a kid in the adrenal glands, but that's an occlusion of the emissary from the adrenal glands. That's not an infarction. That's not a hemorrhage. It's infarction with the hemorrhagic thing developing in the gland that doesn't offload the blood.
So, is it possible for you to stop sharing your screen now, Paul? It's particularly off-putting for me because I can see myself. There we go. Yes, if you stop sharing your screen, just so that you come up on screen.
Stop sharing the screen.
Stop sharing the screen. Yeah, thank you. So you're still sharing your screen?
Yeah. Out.
So the other thing I wanted to ask, and well, it's a question that's been asked as well, is, so now you can put your video back on, but just stop sharing your screen, Paul.
Oh, okay.
So now if you just press stop sharing screen, and then you'll appear on the screen rather than me. So one of the questions, that's perfect, thank you. One of the questions that's been asked is, you demonstrate very clearly through plasma exchange and using anti-CD38 medication, anti-Plasmacell medication, that you get the antibodies down. But do we definitely know that assists in treating the actual condition, whether that be a venous thrombosis or,
That's a good point. In the case number 1, the microthrombi disappeared. So with the lowering of the antibodies, he was having skin microthrombi that disappeared. And in one case, the other case, there was a described improvement on the pulmonary embolism and DVT, which is a bit difficult to believe that only with lowering the antibodies things improve. And also it was a bit debatable why these people had only mycophenolate and cyclosporin, IV, IgG, and nothing else. So I can only say that's what they reported there. But of course, this is only attempts to try and reduce antibody levels from a high titer to minimize the chance of early recurrence. So I don't know what level one can achieve. And of course, it has to translate in something clinical, but we don't have at the moment. In the last case, I'm hoping with such a high level, it doesn't run into an early recurrence. That was the feeling of all the people I spoke to in the panel in Lisbon and also with the people at University College.
And another question I had is, who, we meet people, we meet patients, a lot who have an idiopathic venous thrombosis. They get tested for antiphospholipid antibodies. You find them, they're persistently positive. Who do you decide who should have additional therapy? Do you wait until they have a recurrence, or who would you give?
Are you mentioning plasma cell depletion?
Yeah,
or
plasma cell depletion, and also plasma exchange. Who are the patients that ought to be
I think
receiving?
these are patients who are high risk. And so this person also has got the anti-beta-2 positivity that was shown done in Sheffield, I think. So he's triple positive, very high titers, but hasn't had any infarctions. I wouldn't want to expose him to a risk of recurrence, particularly because we can't monitor at the moment is INR with warfarin. The first patient was just an observation. It wasn't intentionally done. The lady developed CLL, and we saw that the microthrombitis appeared. The other two cases, I can only report what was said. So I think I will go for people of a very high risk, very high titers. I had a cohort of 180 people with antiphospholipids in Naples. We had patients with 5,000, 1,000, 2,000. The lady with 5,000 had a massive cerebral hemorrhage, and the radiologist called her because they felt she had a syphilitic gumma. So the concept of triple positivity is flattening out the concept that above you can have triple positivity at a low level of antibodies, but it doesn't show you whether the person has got 80, 800 or 8,000. And this is Dr. Peng, whom I know very well, has been bombarding us all along for the last 20 years now. First with the dual positivity and then treble positivity, now quadruple positivity. It's a good thing for categorization of studies, but individual patients might not necessarily benefit from that simple categorization as quadruple positivity. It's just to allow studies and people to put together for eventually joint studies.
Yeah, so I think from what you're saying, so obviously, you're thinking that if you do get someone who presents with an idiopathic venous thrombosis, has very high titer anticardiolipin antibodies, anti-beta-2 glycoprotein 1 antibodies, then those are people you might actually even think then should be discussed, perhaps nationally, internationally, to say, do you think this person should be plasma exchange, receive CD38 depletion treatment?
That said, the girl that we treated here with the catastrophic antiphospholipid syndrome, she didn't have a very high titer, to be fair. The anticardiolipin titer was never been positive. It just went up very slowly over time to 14. The DIVT was a bit stronger, but because she went into renal failure, at the time they didn't know what to do, I thought of her doing what I did, and she recovered. So I don't know whether I knew a bit about the background biology of things, so that's what I proposed it to them, and we did it.
And another question that's come up is, out of the two options of plasma cell depletion and beta cell depletion, what's your choice?
They go together because your B cells undergo the isotype switch, go to the marrow, make IgGs. If you've got a constant exposure to the autoantigen, the B cells become memory cells. They're already isotype switched into an lymph node, and you're constantly making IgGs. So if you switch off up front, if you can, B cells making IgGs, you got less chance of the B cells repopulating the marrow as plasma cells.
So if
you prevent that step.
Yeah. So if you had to choose between rituximab and daratumumab, is there one you would choose over the other?
No, I would do them together because you want to stop the B cells populating the marrow as becoming plasma cells. So I give one dose of rituximab there, and then give the daratumumab to switch off the plasma cells. So it's not either; it's together.
Okay. And are there any studies being done to sort of look into this? So I think we might all get a bit twitched that we're immunosuppressing.
There have been studies done in lupus, systemic lupus, where they didn't have antiphospholipids, but of course the pathoautoantibody was the same. In that in the studies using bortezomib, the marrow was repopulated by the plasma cells after 3 months, and the antibodies were reappearing after 6 months, and the clinical symptoms reappeared after 8 months. With daratumumab, it's the same group in Berlin and another group in Sydney. They gave daratumumab, but daratumumab acts also on plasmablasts, and the step before, we call them pre-plasmablast, and the duration of the remission was longer. but then you repopulate, because you're exposed constitute an autoantigen, then the lymph nodes will start making the IgMs, repopulate the marrow, and things come back. So you can see it doing on sort of a regular basis every 6 to 8 months. And I think this is what the group in Berlin is doing.
Okay.
But these people in the studies that I've read, there were no patients with antiphospholipid, but they had the other typical autoantibodies of lupus.
Okay, I've got one final question for you. Who says, devil's advocate, Dr. Ames, in patients who have had warfarin targets increased, because they've had a breakthrough thrombosis in antiphospholipid syndrome, and then they were given treatment that reduced their antiphospholipid antibody titer, would you reduce their warfarin target back down?
Probably. Would you, if the antibodies disappeared, would we stop warfarin? No, because you already had the clot.
It's more.
Probably yes. Probably yes.
Okay.
Probably
okay.
yes.
Yeah. Okay. Right. We'll have to move in the interest of time, but thank you so much for a very interesting and thought-provoking talk. Thank you very much. Thank you.
Thank you.
Right, and last but definitely not least, we're moving to the north of Scotland and Dr. Jo Craig. So Dr. Jo Craig is a haematologist at Regma Hospital in Inverness, and she's a general hematologist. She describes herself as a general hematologist, but she has a special interest in thrombosis and hemostasis. Now she's going to talk to us on a very interesting topic about how we should be managing bleeding in patients who are on DOACs, specifically in Scotland, but obviously this can apply to many other people on the talk as well. So thank you very much, Jo. Over to you.
Thank you, Professor Baggett and Thrombosis UK for the opportunity to speak today. Hopefully this screen is going to share. Are you seeing that now?
Perfect.
Yeah, great. Okay, so I'm here today with my especially colleague, Dr. Jane Rutherford, and we are going to discuss the management of patients who are bleeding on DOACs, specifically with regard to management of those on factor Xa inhibitors who are bleeding and those who are being treated with andexanet alpha, with reference to the current situation in Scotland, but also the rest of the UK. There's a slight difference in the reimbursement for andexanet alpha between Scotland and the rest of the UK, which means that we have been treating slightly different patient groups with andexanet alpha compared with the rest of the UK. So Jane is first of all going to present some cases that we've collected from the local experience here, and then I will try to move my slide on, but it's not working. There's another button before. This one. Here we are. Sorry about that. So we're going to present some local cases, and then there'll be an overview of the andexanet alpha licensing and regional approvals, review of the recent evidence from some clinical trials and studies, and the recent VSH 2026 position statement, and then some thoughts and discussion on the application of these. So over to Jane.
Thank you. So I'm just going to be going through 3 different cases of patients in NHS Highlands who developed thrombosis after receiving andexanet. So we first used our first dose of andexanet in Highlands in April 2021 after its approval, and since then we've used 57 doses for 54 different patients, and the last documented dose that we've given was back in December of 2025. There are other patients, because we've been recording all patients who've received andexanet in Highlands, who have developed thrombotic complications after andexanet, but this has been several months afterwards, or there were other confounding factors that perhaps led to a thrombosis developing. So I won't be presenting them. But since we started using andexanet, we'll probably say about 5 to 6 patients have developed thrombosis, so around a 10% thrombotic rate that we see in our cohort, which is similar to what has been seen in studies. So the first case I want to present is of a woman from February 2024 who had recurrent DVTs for which she was on rivaroxaban. Interestingly, she'd previously received andexanet in June of 2023 after developing a hemothorax after a pacemaker insertion, and she required the DOAC reverse for drain insertion. So unfortunately, this woman had a fall down 6 stairs back in February and sustained a significant head injury and presented with worsening confusion, vomiting and facial laceration, and a CT head done showed a large left-sided subdural with midline shift. She was discussed with neurosurgery and was transferred out of the area to a tertiary centre, and prior to transfer was given low-dose andexanet. She was in the tertiary centre for around a week and was managed conservatively for her subdural, and her rivaroxaban was not restarted. She was transferred back to Raigmore and discharged home on the 21st of February and was not given any anticoagulation on discharge. Just over a week later, she represented with worsening confusion and word-finding difficulties, and unfortunately her subdural had worsened and she was transferred directly to the neurosurgical centre. She underwent a left-sided burr hole and post-op was commenced on 2,500 units of dalteparin. When she was transferred back to Raigmore, we switched her over to prophylactic enoxaparin, and she was discharged on the 15th of March, and again no anticoagulation was given on discharge. Unfortunately, a week later, she presented with acute onset of right leg swelling, and this was confirmed to be a DVT on ultrasound. Discussions were had around her anticoagulation, and she was started on apixaban at 10 milligrams initially, to then reduced to 5 milligrams twice a day for 3 weeks, and then lifelong 2.5 due to concerns about falls risk. So her DVT developed within 38 days of having her andexanet. Since then, she's had no issues with recurrent bleeds or thrombotic episodes, and the patient is still alive today. The second case I want to discuss is a gentleman from May of 2024 who was on doxaban for atrial fibrillation, and he initially presented to a rural district general hospital within NHS Highland with groin pain due to a long-standing hernia. He had a CT scan in the emergency department which showed an incidental finding of a AAA, and that evening the images were reviewed by our vascular team, who felt that the AAA showed slightly atypical features, and he was to be brought back to the department for a CT angio the following day. When we presented, he had a transient loss of consciousness, and the CT showed a ruptured AAA with a large retroperitoneal hematoma, which you can see there. He was urgently transferred to Raigmore under the vascular team, was discussed with ourselves, and was given low-dose andexanet. On the same day as transfer, he had an open repair of his ruptured AAA, was intubated and in ITU post-op, and required 6 units of red cells during the operation. The following day, he developed a post-op ischemic right leg and went back to the theatre for a fempop bypass and embolectomy, and also actually had a sigmoidoscopy carried out at the same time because he developed melena in ITU. The sigmoidoscopy at the time showed patchy ischemic changes, but no intervention was required at that time, and he was commenced on a heparin infusion post-operatively. The following day, he went back to theatre for a repeat sigmoidoscopy due to concerns about ongoing melena, and that confirmed infarcted bowel, and he underwent an emergency laparotomy with a subtotal colectomy and ileostomy, and again the IV heparin was recommenced. He was on his heparin for 5 days and then switched over to enoxaparin, and he slowly improved in ICU and eventually stepped down to ward level care in mid-June and switched to apixaban. He was discharged from hospital in July of that year, was home on apixaban and aspirin. Again, no further documented episodes of bleeding or thrombotic episodes since then, and the gentleman is still alive today. And the third and final case to present is from July of 2024. I'm a 62-year-old woman with known atrial fibrillation, but not actually on any anticoagulation at the time of her admission to hospital. She did have significant cardiac history with a previous VT arrest, an ICD and QTC prolongation. She was deemed a low risk for stroke with a CHA2DS2-VASc score of 1, and her case had actually previously been discussed with her cardiologist, who advised that she did not require anticoagulation due to her low risk. So she was admitted at the end of July with a 2-day history of abdominal pain, was significantly unwell and very hypoxic, and was commenced on 5 litres of oxygen, IV antibiotics, and a CT scan was organised. She had a very high CRP and an acute kidney injury at presentation. Her CT showed left lower lobe pneumonia and left-sided colitis, and her antibiotics were escalated. Unfortunately, she continued to deteriorate over the next 24 hours and needed transfer to our medical high dependency unit for high flow oxygen within 24 hours of admission. She remained in MHDU. There was ongoing issues with fast AF, but over the next few days, her renal function improved and she was commenced on prophylactic enoxaparin. On the 29th of July, it was decided to start her on apixaban 5 milligrams BD because she was slowly improving, her renal function was better, and because of her known atrial fibrillation. 2 days later, she developed worsening abdominal pain, and a chest x-ray was carried out, at which you can see air under the left hemidiaphragm, and she developed bowel perforation with small bowel ileus as well. She was taken for an emergency laparotomy, and she was discussed due to the apixaban and was given low-dose andexanet. She had a laparotomy with a subtotal colectomy and end ileostomy, and was in surgical high dependency for 3 days, and then discharged home on 40 milligrams of prophylactic dose of Clexane on the 12th of August. Unfortunately, just over a week later, she presented with word-finding difficulties, was seen by the stroke team and was felt to have had a left pax, and was commenced on apixaban 5 milligrams twice a day and discharged 2 days later. Again, no longer than 2 weeks after that, she re-presented with right-sided arm weakness and altered sensation and was diagnosed with brainstem stroke. Her anticoagulation was not changed at this point, and she remained on 5 milligrams BD of her apixaban. So this woman developed ischemic events at days 21 and 36 after andexanet. Unfortunately, the patient died in the community in October of the same year, and the cause of death on the certificate was stroke secondary to atrial fibrillation. I think this case in particular is very interesting, given that this was a woman in her 60s who was deemed low thrombotic risk, low stroke risk, and was not on any anticoagulation, who then was given andexanet and then developed 3 subsequent thrombotic events and ultimately led to her death. So those are our 3 cases from NHS Highland, and I'll just hand back to Jo.
Thank you, Jane. So the benefits of the direct oral anticoagulants are well documented, but major bleeds do unfortunately still happen, despite the fact that they are associated with lower risk for major hemorrhage compared with something like warfarin. So there can still be a high mortality associated with these major bleeds, and we actually want to try to do something about that. We have few agents available to us for these patients. We have idarucizumab for reversal of dabigatran effect. We have andexanet alpha, which is licensed for reversal of apixaban or rivaroxaban for life-threatening or uncontrolled bleeding, and it has some efficacy in the reversal of the edoxaban effect, although that is unlicensed. And there's 4-factor prothrombin complex concentrate in the form of prothromplex or veriplex and optiplex, but they are also unlicensed for this indication. So specifically looking at andexanet alpha, because most of the patients who are anticoagulated now are on apixaban or rivaroxaban, and most of the bleeding events we have seen have been related to those drugs. We are particularly concerned about andexanet alpha use. Going back a bit, this was initially granted accelerated approval by the FDA in 2018, but there was a requirement that the drug company had to conduct a randomized controlled trial in patients with intracranial hemorrhage. An approval in Europe and the UK followed, and in 2020 the Scottish Medicines Consortium accepted andexanet alpha for use on an interim basis, subject to ongoing evaluation and future reassessment. And NICE recommended use for andexanet alpha in the rest of the UK subsequently, but only for those who had bleeding in the gastrointestinal tract, whereas in Scotland there was no stipulation on the site of bleeding that the patient had for the drug to be used. These approvals were based on the ANEXA-4 trial, which was a prospective single-arm trial for patients with major bleeds who had anti-10A levels of greater than 75 nanograms per mil and had received a factor 10A inhibitor in the previous 18 hours, should say 18 there. They excluded patients with a poorer prognosis. The mean factor 10A activity was reduced by 93%, and hemostasis was judged as excellent or good in 82% of patients overall, but a 10% thrombosis rate was reported within 30 days. There was no comparator arm in this study. So as mandated by the FDA, the ANEXA-I trial was carried out to investigate the use of andexanet alpha versus usual care in patients with intracranial hemorrhage. There were some early protocol amendments limiting this to intracerebral bleeding only. Again, those with poor prognosis were excluded, along with those likely to need surgery within 12 hours or who had a history of thrombosis in the previous 2 weeks. Patients are randomized 1-to-1 to receive andexanet alpha or usual care. In the usual care arm, 85.5% of patients received 4-factor PCC, but it is not known what therapies, if any, were given to the other 14.5% of patients in that group. And the trial was terminated early when the primary endpoint of hemostatic efficacy was met for the first 452 patients, with reduced hematoma expansion seen in 67% of andexanet alpha treated versus 53% of the usual care patients. But there were higher rates of thrombotic events, mostly ischemic stroke and MI in the andexanet alpha arm at 10.3% versus 5.6%. And when the FDA independent review was carried out, the number of thrombotic events was judged to be higher than this at 14.6% for andexanet alpha treated patients versus 6.9% for the usual care group. The trial unfortunately wasn't powered to detect differences in deaths or functional outcomes at 30 days, so we don't really know if this reduction in hematoma expansion for andexanet alpha treated patients translates to better outcomes. Following this, AstraZeneca withdrew andexanet alpha from the US market. NICE terminated the appraisal for reversal of anticoagulation in people with intracranial hemorrhage due to non-submission by the drug company. The guidance to restrict use for patients with GI bleeding only remains. However, the EMA and the MHRA have renewed marketing approval for andexanet alpha, and in Scotland we don't have any updated guidance from the SMC, and I believe that is dependent on whether the drug company make a new submission or not. So ANEXA-I is our only prospective randomized controlled trial for intracranial hemorrhage management for these patients. There have been some retrospective cohort studies carried out looking at these cases which do not show significant improvement in outcomes for 4-factor PCC. So we don't really know if that is actually better than andexanet alpha, although we do know that it seems to be associated with reduced rate of thrombosis. And a further retrospective study compared the outcomes of patients with intracranial hemorrhage, including subarachnoid hemorrhage and subdural hemorrhage, who were treated with andexanet alpha with those receiving 4-factor PCC. And in this study, hemostasis was judged to be better in those receiving andexanet alpha, but higher rates of thromboembolic events were again reported. So guidelines are available for stroke in the UK, and the National Clinical Guideline for Stroke advises against the use of andexanet alpha for patients with intracerebral hemorrhage unless they're in a randomized controlled trial. They do recommend that the use of 4-factor PCC can be considered. For GI bleeding, we don't have a randomized controlled trial, but we do have the recently published data from the Rapido study, which was a UK-wide analysis of over 2,000 patients receiving a reversal agent for direct oral anticoagulant-associated bleeding. There was no significant difference in deaths at 90 days, but there was again higher rate of arterial thrombosis at 30 days and a higher rate of DOACs and TIAs driving that for the andexanet alpha treated patients. Another large observation study has suggested a possible in-hospital mortality benefit for andexanet alpha over 4-factor PCC. This was a cohort study of over 4,000 patients showing this reduced in-hospital mortality, and this appeared to be the case for those with intracranial hemorrhage and those with GI bleeds, but there's no data on thrombotic events, and there are other retrospective observational studies available, but they are all subject to the same selection bias and patient heterogeneity that these studies are subject to. There are some meta-analyses also looking at the retrospective studies, and they have not found any significant difference in hemostatic effectiveness and thromboembolic events between patients treated with 4-factor PCC or andexanet alpha. And we're also looking at what evidence we have for patients who have traumatic injuries causing their bleeding. We don't have any randomized control trial evidence for these patients either. There are some guidelines available. The European Trauma Guideline recommends administration of andexanet alpha as first-line therapy, whereas the European Society of Anesthesiology and Intensive Care Guideline recommends the use of andexanet alpha or four-factor PCC for severe or life-threatening bleeding. However, in Scotland, we have recently had publication from the Scottish Trauma Network. This was following a review triggered by a case where there was a traumatic injury and the patient was on rivaroxaban, received andexanet alpha and had significant thrombotic complications. Following this, the Scottish Trauma Network does not recommend the routine use of andexanet alpha in patients on apixaban or rivaroxaban with life-threatening traumatic major hemorrhage, although it could be considered after MDT discussion in patients who are not responding to other measures and where death from exsanguination is thought to be the likely outcome. And last month, there was publication of the British Society for Haematology position statement for use of andexanet alpha. They have advised that clinicians should be aware that administration of andexanet alpha is associated with a significantly increased risk of thromboembolic events, particularly ischemic stroke. And if administration of andexanet alpha is being considered, clinicians should be aware that thromboembolic risks may outweigh benefit. And if andexanet alpha is to be given, clinicians should also ensure that it is only administered within its licensed indication. They've advised that the previous British Society for Haematology recommendations for the management of bleeding in patients on antithrombotic agents remain unchanged, and a full updated guideline is currently in preparation. The previous guidelines are from 2013, so predate the licensing of the current reversal agents and antidotes. However, I think they still contain some important general non-pharmacological measures. And in particular, I think if we are speaking with clinicians who have a bleeding patient, we need to remind them about the use of mechanical pressure and also the use of endoscopic, radiological or surgical measures as far as possible. And of course, to get baseline blood tests in the patient and try to find out when the last dose of the DOAC was given. So how should we be managing bleeding in these patients in Scotland, but also in the UK and in general? I think we should be doing that according to the BSH guidance and within the licensing, and also considering the following points specific to andexanet alpha use if this is going to be considered. I think we need to avoid using this if a patient is likely to need vascular or cardiac surgery imminently due to the fact that it confers heparin resistance, and the drug is not licensed for use for patients who require imminent surgery in general. We also have to remember there's an anti-tissue factor pathway inhibitor effect for several hours, and this could be particularly important for patients who are at higher risk for DIC, such as trauma patients or people who have sepsis. Locally, we've had some practical issues with the fact that the andexanet alpha is given as a bolus followed by an infusion, and if patients require transfer to tertiary centres, this is not particularly easy to manage, and we switched to four-factor PCC already for those patients. There's often difficulty ascertaining the time of the last dose of DOAC in unwell patients, and there is limited availability of testing for drug levels, plus decisions often have to be made quite quickly before these results would be available. And we have this uncertainty of the efficacy associated with what appears to be a real risk of harm for these patients, especially those with intracranial hemorrhage, and careful patient and family or carer counselling is required, I think, if this drug is to be administered. And it remains a high-cost drug compared with alternatives such as four-factor PCC. However, there remains question over the value of either of these, and I think further good quality trial evidence is definitely needed. Just to return to the 3 patients that Jane presented, I think for similar cases in the future, we would most likely be avoiding the use of andexanet alpha, given that the first patient had intracranial hemorrhage. The second was a patient on edoxaban, and the drug is not licensed for reversal of edoxaban effects. And in the third patient, the main indication was the fact that the patient required urgent surgery, and I think we would try to avoid using andexanet alpha there as well. And I'll just leave you with a nice picture of early morning at Loch Ness. And thank you for your attention, and we're happy to take any questions or comments.
Lovely. Thank you so much, Jane. Apologies, Jane, for not introducing you at the beginning. Thank you very much for presenting those cases really, really carefully. And, you know, thank you for your honesty about, you know, saying, well, those 3 cases in hindsight, we would probably now manage differently. And you summarize, your summary at the end was absolutely fantastic. You know, really sort of shows, I think, that we've been waiting for a reversal agent for the direct oral anticoagulants for years. We felt it was such an issue, you know, whereas before we had, or we still have, the 4-factor PCCs for reversing warfarin so beautifully. When DOACs came along, we thought, well, we need a reversal agent. A reversal agent comes along for the most commonly used DOACs, the 10A inhibitors, and we're so thrilled. But actually, it has its problems, and I think that what everyone is trying to do, what you've just done with this talk, what BSH are trying to do, is say it's there, but only use it if you really have to, because we don't know about that there's true benefits. I've just had a question come in. Yeah. Oh, right. So yeah, someone's just asking here, and you sort of alluded to it, Joe. The question here: there's a clear signal about thrombosis, particularly arterial, but do you have any idea about the potential mechanism? And I think in answer to that question, Joe had mentioned about the TFPI effect. So the structure of andexanet can not only bind to 10A, but it can also bind to TFPI, and it seems to be pretty clear that it's actually inhibiting TFPI and leading to a more prothrombotic state. So that's and there's been some really good work being done on that down in London, that we think that's the mechanism for the increased thrombotic risk. I wouldn't like to say it's been proven yet, but we think that's the reason why. Yeah, there's another question here now as well. We don't use andexanet for any patients now in our trust due to the risk of thrombosis and no clear mortality benefit, but we are using fresh frozen plasma. And the doxaban, if a patient takes this routinely, is it advised to continue this post-operative or switch to apixaban or something else? It's not, I don't know if what you're thinking of is that, you know, we can't reverse a doxaban. That is true. There isn't a license for andexanet to reverse a doxaban, but I don't think anyone would necessarily be saying that you have to switch them off apixaban. Lachelle, I'll answer that. There's a question here about are there any insights as to why the FDA and EMA have come to different conclusions about licensing status. I don't know whether I don't know in answer to your question, and whether the EMA will change their mind, I don't know, but it certainly doesn't seem to be the case. I realise we're 3 minutes over time. I want to hugely thank the speakers for all that effort they put into 4 absolutely fantastic talks, loads of food for thought. And thank you all for attending. We hit a peak of 311 attendees, and those are just the people that have been attending live. We know that we've got over 3,500 that are actually registered for the National Thrombosis Week run by Thrombosis UK. So I probably need to bring it to an end there. But thank you all for joining, and thank you to our speakers, and enjoy the rest of your day. Thank you very much.